Hello. So we are going to continue with our second class regarding tuberculosis. So in the first class we learned regarding the method of diagnosis of tuberculosis and the treatment of drug sensitive TB. In this class we are going to know regarding the national program with in relation to tuberculosis, its evolution, its present status, and discuss regarding the treatment of drug resistance TB. So coming to the evolution of TB control in India. So tuberculosis always have been a very important public health problem in India since the 50s and 60s. So in 1962, the National TB program was launched. In 1992, the National TB program, that is the NTP, was reviewed, as only 30% of the patients were diagnosed according to that program, and of this only 30% were treated successfully. In 1993, the National Tuberculosis Program was revised and called Revised National Tuberculosis Control Program. A pilot phase was started, and in 1997 the RNTC program was launched over the whole of India. In 2004, within 2004, about 80% of the country was covered by that program. In 2006, Top TB program as was launched by World Health Organization. In 2015, NTB program was started, and in 2019, revised National Tuberculosis program was reviewed, and National Tuberculosis Elimination program was started in India. So what were the drawbacks of National Tuberculosis Control Program? Managerial weaknesses was one of the cause, inadequate funding, over-reliance on X-ray for diagnosis, interrupted supplies of drugs or poor quality of drugs, and low rates of treatment completion. So in the National Tuberculosis Program, mainly X-ray was used for the purpose of diagnosis. Drug regimens were irregular, and follow-up of the patients were not good. So revised National Tuberculosis Control Program was thereafter launched, first in as a pilot basis in 1993, thereafter in 1997, and it was mainly based on the World Health Organization DOT strategy, which we had discussed in the last class. So it was a 100% centrally sponsored program. Government of India sponsored the program. All components of the Stop TB Strategy 2006 are being implemented presently. So what were the objectives of RNTCP? Number one, achievement of at least 85% cure rate of infectious cases of TB through DOTs involving peripheral health functionaries. And number two, augmentation of case finding activities through quality sputum microscopy to detect at least 70% of estimated cases. Coming to the components of Stop TB strategy, which was launched in 2006 by World Health Organization. Pursuing quality DOTs, expansion and enhancement, addressing TB, HIV and multi-drug resistant tuberculosis. Contributing to health system strengthening, engaging all healthcare providers, empowering patients and communities, and enabling and promoting research. Now coming to the End TB strategy as launched by World Health Organization. It consists of integrated patient-centered care and prevention, bold policies, and intensified research and innovation. So what is the 90-90-90 targets in relation to End TB strategy? To reach at least 90% of all people with TB to give treatment, to reach at least 90% of the key populations. Who are the key populations we are going to discuss in the next slide, and to achieve at least 90% of treatment success. So that is the 90-90-90 targets. So who are the key populations? Number one, people who have increased exposure to TB due to where they live or work, just like medical professionals. To number people who have limited access to quality TV services, like those who living in very remote areas. Number three, people with increased risk of TB due to biological and behavioral factors. For example, patients receiving corticosteroid therapies or suffering from immunocompromised disorders or cancer patients. So now coming to the National Strategic Plan for TB elimination. The objectives were to achieve more than 90% notification rate, more than 90% treatment success of all new TB cases, more than 85% treatment success for retreatment of recurrent cases. Just here, it is better to know that the World TB Day is celebrated on 24th March. Now, we should know a little bit regarding the organization of this TB program. So, the state TB office is manned by the state TB officer. The state TB training and demonstration center is headed by the director. The district TB center is headed by the district tuberculosis officer, under which comes the TB unit, which is manned by the medical officer TB control, senior treatment supervisor, that is STS, senior TB laboratory supervisor. Under the TB units come the microscopic centers and treatment centers, and last but not the least are the dot providers. So, going through the laboratory network under this program, so there is the central TB division, under which comes the national reference lab. Then comes the state TB cell, under which comes the intermediate reference lab, under which is the district TB center at district level, under which comes the tuberculosis unit, and under each tuberculosis unit comprises of 3 designated microscopic centers. So, what are the RNTSP endorsed diagnostic methods? So, it is number one is the smear microscopy for AFB, that is sputum smear for ZN staining, or fluorescent stains examined under direct or indirect microscopy without lead. Second, coming to culture, solid LJ media or liquid medium using automatic or semi-automatic machines like BACTEC. Number 3, the rapid diagnostic molecular test, the conventional PCR based line probe assay, or the real-time PCR based nucleic acid amplification test, that is the gene expert, that is the CBNAT or the TrueNAT. Now coming to DOTS plus, that is the programmatic management of drug resistance TB. So here resistance may be divided into 2 types: primary or pre-treatment resistance, secondary or acquired resistance. So what is primary or pre-treatment resistance? Resistance shown by a bacteria in a patient who has not received the drug before. And secondary or acquired resistance may be patient has become resistant during the course of treatment. So what are the components of DOTS plus? In short term, develop national emergency response plans for MDR and XDR TB and ensure basic TB control. Conduct rapid surveys of MDR and XDR TB cases to assess vulnerable population. Strengthen and expand national laboratory capacity. Implement infection control precautions in healthcare facilities. And in long term, capacity building of clinical and public health managers. Promote universal access to antiretroviral therapy in HIV patients, and support an increase in funding for research. So we should know a few of the definitions which are related with this program. So what do you mean by drug susceptibility testing? DST refers to in vitro testing using either of the phenotypic methods to determine susceptibility. Drug resistance testing, DRT, refers to in vitro testing using genotypic methods, molecular techniques to determine resistance. Multi what do you mean by multi-drug resistant TB? A TB patient whose biological specimen is resistant to both isoniazid and rifampicin, with or without resistance to other first-line anti-TB drugs. So, MDR TB patients may have additional resistance to any or all fluoroquinolones or any other anti-TB drugs. Coming to what is extensively drug resistance TB. Tuberculosis caused by Mycobacterium tuberculosis strains that fulfill the definition of MDR or rifampicin resistance TB and are also resistant to any fluoroquinolone like levofloxacin or moxifloxacin, and at least one additional group A drug, presently to either bedaquiline or linezolid or both. What are the group A, B, C drugs? We shall discuss later on. Next, what is monoresistance TB? A TB patient whose biological specimen is resistant to one first-line anti-TB drug only. What is polyresistance TB? A TB patient whose biological specimen is resistant to more than one first-line anti-TB drug other than both isoniazid and rifampicin. What is isoniazid resistance TB? A TB patient whose biological specimen is resistant to isoniazid and susceptible to rifampicin has been confirmed. Now coming to what is presumptive TB. This refers to a person with any of the symptoms or signs suggestive of TB. But we have to keep in mind that diagnosis of TB is difficult in certain key groups of the presumptive TB patients like extrapulmonary TB, people living with HIV, children, smear negative, X-ray suggestive of TB not available, other vulnerable groups, or drug-resistant TB contexts, where CBNAT is offered as the first line method of diagnosis. So now coming to the classes of anti-TB drugs recommended for treatment of drug-resistance TB. It is divided into three groups. Group A include all three medicines. So number 1, levofloxacin or moxifloxacin. Number 2, bedaquiline. Number 3, linezolid. Group B, add one or both medicines. Number 1 is clofazimine. Number 2 is cycloserine or terizidone. And group C, add to complete the regimen and when medicines from group A and B cannot be used. So number 1 is ethambutol, number 2 is delaminide, number 3 pyrazinamide, number 4 imipenem, cilastatin or meropenem, number 5 amikacin or streptomycin, number 6 ethionamide or prothionamide, and number 7 p-aminosalicylic acid. So now coming to the very important part, that is the treatment of drug resistance TB. So before going to the treatment of drug resistance TB, let us classify the different regimens of drug resistance TB. So number 1 is the isoniazid mono or the polydrug resistance TB. That is rifampicin resistance not detected and isoniazid resistant is detected. This is the number 1 group. Number 2 group is the shorter MDR TB regimen, and the number 3 group is all oral longer MDR TB regimen. So let us go know the first treatment of the first group, that is the isoniazid monoresistance or polydrug resistance TB. All oral isoniazid mono polydrug resistance TB regimen. So what is the regimen? That is, here we don't divide it into intensive phase or continuation phase. Here treatment is given for 6 months with 4 drugs, that is rifampicin, ethambutol, pyrazinamide and levofloxacin. It is given for 6 months, maybe continue till 9 months. Now coming to the treatment regimen of shorter duration MDR TB regimen. So here there is resistance to rifampicin, but not to the second line injectables or fluoroquinolones. So in intensive phase, that is for 4 to 6 months, we give kanamycin, high dose moxifloxacin, clofazimine, pyrazinamide, isoniazid and ethambutol. And in the continuation phase, that continues for 5 months, we drop 3 of the previous drugs and give high dose moxifloxacin, clofazimine, pyrazinamide and ethambutol. Now here we should add one thing, that according to the latest guideline, Government of India is trying to omit the injectables from this regimen and go into all oral drugs regimen. That is the short duration MDR regimen with all oral drugs. This is actually coming recently and will gradually replace the shorter duration MDR TB regimen. So a shorter oral betaquilin containing MDR RR rifampicin resistant TB regimen of 9 to 12 months duration is recommended in eligible patients with confirmed MDR TB or rifampicin resistant TB who have not been exposed to treatment with second line TB medicines used in this regimen for more than 1 month and in whom resistant to fluoroquinolones have been excluded. So what is the regimen? In intensive phase, we give bedaquiline, levofloxacin, clofazimine, pyrazinamide, ethambutol, isoniazid and etionamide. This is given for 4 to 6 months, where bedaquiline is given for maximum of 6 months, not more than that. And in continuation phase, we give for 5 months, that is levofloxacin, clofazimine, pyrazinamide and ethambutol. Now coming to the longer duration all oral MDR TB regimen. So who are giving longer duration MDR TB or XDR TB regimen? This is for those patients who are resistant to fluoroquinolones or second line injectables, INHA mutation for ethionamide, resistant to pyrazinamide, intolerant to fluoroquinolones, second line injectables, ethionamide or clofazimine, in pregnancy, in persons pulmonary tuberculosis in persons living with HIV, disseminated TB or CNS TB. So what is the regimen? Here we give bedaquiline, levofloxacin, linezolid, clofazimine and cycloserine. No intensive phase or continuation phase, it is separately divided. Total duration is 18 to 20 months. New drugs like bedaquiline and delaminide would be given for 6 months duration, while the dose of linezolid will be tapered to 300 mg after the initial 6 to 8 months of treatment, because linezolid causes thrombocytopenia. This regimen will also be used for treatment of XDR TB patients with 20 months duration. So what is the principle of designing a WHO recommended all oral longer MDR TB regimen? So in MDR TB or rifampicin resistant TB patients on longer regimen, all 3 group A agents, that is levofloxacin or moxifloxacin, bedaquiline and linezolid, and 1 group B agent, clofazimine and cycloserine, should be included to ensure that treatment starts with at least 4 TB agents likely to be effective, and that at least 3 agents are included for the rest of the treatment after bedaquiline is stopped. If only 1 or 2 group A agents are used, both group B agents are to be included. If the regimen cannot be composed with agents from group A and B alone, group C agents are added to complete it. So what are the inclusion criteria for newer drugs like bedaquiline or delaminide? Bedaquiline and or delaminide can be provided to the patient if more than 18 years of age. Delaminide can be provided to age group from 6 to 17 years. Use of bedaquiline for 6 to 17 years and delaminide for 3 to 6 years may be considered only after approval from DCGI. Non-pregnant females or females not on hormonal birth control methods are eligible. They should be willing to continue practicing birth control methods throughout the treatment period or have been postmenopausal for at least 2 years. Patients with controlled stable anemia can be considered after obtaining cardiac consultation. So, pre-treatment evaluation for drug-resistant TB patients. History and physical examination has to be done. Height, weight measured, random blood sugar check, chest X-ray, HIV testing. No additional testings are required for isoniazid mono or poly drug-resistant patients unless clinically indicated. So, pre-treatment evaluation for MDR or rifampicin treatment patients. This is required as lot of toxic drugs are being given. So, complete blood count, blood urea creatinine, audiometry only if on injectables, liver function test, thyroid stimulating test, urine examination, psychiatric evaluations, electrolytes, serum protein, ECG, if on moxifloxacin, bedaquiline, clofazimine or delamine, urine pregnancy test, ophthalmological opinion to rule out chorioretinitis or uveitis only if on linezolid. Surgical evaluation should be done at appropriate time if required. So this chart is very important. We shall be going to and fro between this slide and the next slide. So that is the integrated drug resistant algorithm. So we get a group of patients who are considered to be presumptive TB, especially people living with HIV, extrapulmonary TB, smear negative or X-ray smear negative TB or X-ray suggestive of TB, including pediatric TB, vulnerable populations, contact of drug resistant TB patients, all notified TB patients, all non-responder to treatment has to undergo CBNAT examination. So the non-responder to treatment will include drug-sensitive TB patients as well as isoniazid mono and polyresistant. So the result of CBNAT may show two results. It may detect rifampicin resistance or rifampicin resistance may not be detected. First, let us discuss rifampicin resistance not detected. So, if a patient underwent CBNAT and rifampicin resistance was not detected, the patient will undergo first line probe assay. Meanwhile, receiving the first line TB treatment. So, here also rifampicin resistant is not detected. So, we will continue the first line, the treatment with first line drugs. If rifampicin resistance is detected, the patient will undergo second line LPA or liquid culture drug susceptibility testing. All and will receive all oral isoniazid mono or poly drug resistant TB regimen. So, patients receiving all, which patients will receive all oral H mono or poly regimen. So, isoniazid resistant TB with confirmed result for rifampicin resistance and for rifampicin resistance not detected. Exclusion criteria: no specific criteria except drug interaction intolerability with any other drug used concomitantly. Now coming to the patients in whom CBNAT detects rifampicin resistance is present. So the patient will undergo first line and second line LPA and liquid culture drug susceptibility testing. So here, which patient will receive shorter MDR TB regimen and which patient will receive longer MDR TB regimen, that has to be determined. So shorter MDR TB regimen, patient with rifampicin resistant pulmonary or extrapulmonary TB will receive shorter MDR TB regimen. But what is the exclusion criteria? Which patient will not receive the shorter MDR TB regimen and will go to the all oral longer MDR TB regimen? So the drug susceptibility testing base criteria, it will be based on the exclusion criteria will be based on the drug susceptibility testing base criteria. If drug susceptible testing or drug resistance testing result for fluoroquinolones or the second line injectables is resistant, or presence of INHA mutation for ethionamide or resistance to pyrazinamide. If drug susceptibility testing result is not available, history of use for more than 1 month of anti-TB drugs, intolerance to moxifloxacin, kanamycin, ethionamide or clofazimine, and non-drug susceptibility testing best criteria, that is pregnancy, any extrapulmonary disease in people living with HIV, disseminated meningococcal central nervous system TB, intolerance to any drug in the shorter MDR TB regimen or risks of toxicity from a drug in the shorter regimen, will receive the all oral longer MDR TB regimen. So all oral longer MDR TB regimen is received by patients in whom shorter MDR TB regimen cannot be considered due to the above reasons. So the treatment duration for all oral isoniazid mono or poly drug resistant TB regimen, the intensive phase is given from 6 months, may be prolonged for up to 9 months. For so there is no separate division of intensive or continuous phase. It is given for 6 months continuously. If required, it may be extended up to 9 months. For shorter MDR TB regimen, the intensive phase is given for 4 months. Extended intensive phase, it may be extended for another 2 months, and for the continuous phase for 5 months. So the total duration is 9 to 11 months. And for all oral longer MDR TB regimen, intensive phase is for 6 months. Extended, it may be extended for another 2 months, or for continuous phase it is 12 months, and total duration is 18 to 20 months. So as patients will be receiving multiple drugs in all these regimens, clinical monitoring to find out any drug toxicity is important. After initiation of treatment from the drug resistant TB center, AMO, the medical officer of that center will review the patient at monthly intervals during the intensive phase, at 3 monthly intervals during the continuation phase until the end of the treatment. Assess clinical, microbiological and radiological response and to treatment. Measure weight, assess possible adverse drug reactions, encourage the patient to continue treatment, verify treatment card. So how to follow up these patients? For all oral regimen for isoniazid mono or polydrug resistance TB, clinical examination and weight measurement has to be done monthly. Smear microscopy monthly from 3rd month onwards. Culture at the end of 3rd, 6th and 9th month if applicable. And shorter MDR TB regimen, clinical examination and weight monthly in intensive phase, quarterly in continuation phase. Smear microscopy has to be done monthly from 3rd month onwards till end of intensive phase. Monthly in extended intensive phase only if previous month is sputum positive. Culture at 3rd, 6th and month and at the end of treatment. And for the all oral longer regimen for MDR or rifampicin resistance TB, clinical plus examination plus weight monitoring monthly in the first 6 months, quarterly beyond 6 months. Smear microscopy with culture at the designated culture drug sensitivity labs. Culture monthly from 3rd month onwards to the end of 6 months, quarterly beyond 6 months, 2 consecutive monthly culture if any culture positive from 6 month onwards. So what is the treatment outcome? Outcome for drug resistant TB patients treated on saline drugs can be cured, treatment completed, treatment failed, died, lost to follow up, not evaluated, treatment success or cohort. So changes, what are the changes in the national tuberculosis elimination program, the changes which occurred from the revised national tuberculosis program. So weekly regimen, previously in revised national tuberculosis program, it was a weekly regimen where the anti-TB drugs were given thrice weekly. Now they are given daily in the national tuberculosis elimination program. Nowadays, drugs are given as fixed dose combination to reduce the pill burden. Category 2 has been removed. So the backbone of the management of TB now is based on the drug susceptibility testing. Now ethambutol has been added in the continuation phase. Previously, in the revised national tuberculosis program, two drug were given in the intensive phase, 4 drug was given in the intensive phase and 2 drug in the continuation phase, while in the national tuberculosis elimination program, 4 drug are being given in the intensive phase and 3 drugs are being given in the continuation phase. No extension of intensive phase is being done despite absence of sputum conversion. Long-term follow-up is being done, both laboratory and clinical. Changes in management of drug-resistant TB has taken place. Drug sensitivity testing has been made universal, and 5 weight bands are there instead of 4, which was present previously in the revised national tuberculosis program. Coming to few of the new initiatives, so that is the NICSHA program, that is the integrated information communication technology based program. So every patient of tuberculosis has to be registered nowadays in the NICSHA software. It is an online monitoring software to get notification of TB cases, continuous monitoring of treatment, and all registered cases are followed up through the NICSHA software. Coming to DOTS 99, it is also a information communication technology based system to improve compliance to medications. Blister packs with hidden toll-free number are provided, which is revealed as the patient takes the tablet. Next is the NICSHA Poshan Yojana. NICSHA Poshan Yojana is a government scheme in India to provide rupees 500 per month to a tuberculosis patient to buy food. So what are the do's and don'ts for the patients? So infection controls do's: cover your mouth with a tissue, handkerchief, or upper sleeves of your clothing while coughing. Wash your hands with soap and water or an alcohol-based hand wash. The room where the patient stays for a considerable time should be well ventilated with proper sunlight. Any family member who develops cough should be followed up, should also follow similar cough etiquette. And do not cough and spit in the open. Do not close or obstruct your windows to ensure proper ventilation. And regarding nutrition, take complete meals inclusive of dal, roti, vegetables, eggs, fish, meat. At the start of the treatment, there may be some nausea and stomach upset, so you should consult your doctor. And do not stop or skip any meal. Regarding side effects, if you have any side effects or discomfort on taking treatment, report to your doctor. For any other illness which develops during treatment, you should consult doctor. And don't be complacent about side effects or discomfort. Do not try to take medications for side effects on your own. Carry your treatment booklet. Take your medicines regularly and complete the full course of treatment as prescribed by the medical officer. Advice on family planning infection control. All the drug-resistant TB patients are advised to use contraception during treatment period. If pregnant drug-resistant TB patient, seek expert. If a drug-resistant TB patient is pregnant, seek expert consultation for advice on medical termination of pregnancy and appropriate treatment regimen. Thank you. So with that, we end our class on tuberculosis. So to summarize, nowadays, according to the National Tuberculosis Elimination Program, TB patients are mainly diagnosed on the basis of sputum smear examination and chest X-ray, and all are subjected to CB-NAT examination. Through CB-NAT examination, we divide the patient into two categories, that is patients, the drug sensitive TB patients and drug resistant TB patients, and subject them to appropriate medications as per guideline. Thank you.